Hi Ninja Nerds, in this video we're going to talk about cirrhosis. If you like this video, give it a thumbs up, comment down below, and don't forget to subscribe. And then check out ninjanerd.org where we have all of our notes and illustrations for every lecture we put up here on YouTube. But let's get started with cirrhosis. So when we focus on cirrhosis, we're focusing on the liver, right? And the liver located in the right upper quadrant of our abdomen and its function. And we need to talk about first, what is cirrhosis specifically? So cirrhosis is this fibrotic decrease in the ability for the liver to function properly. So what happens? So over time, there is a lot of stress and chronic, irreversible damage to the liver. And that is what we call the scarring, right? So this scarring causes an impediment of the proper function of the liver. And if we have to think back to our pathophysiology and think back to our anatomy and physiology, what is the function of our liver? What are the processes that our liver helps with? When we want to start thinking about our liver, people usually think of it as like the filter, or it helps do all these things, but what are some of those things? We want to think about absorption. So it's going to help us absorb. It helps us do some production. But what it really does is it helps us detoxify. Okay, and we want to start thinking about how does that work. So let's go back to anatomy and just go over some of the structures here really quickly of what these are and what's going on with our liver. So our liver, right here, is located at the top here for us, and we want to think about this being our right upper quadrant here. And there's a couple more organs here that help with our liver function and contribute to the liver's function. The first one here being our pancreas. And our pancreas does a lot of different things, but what is one of the big functions of our pancreas is the production of insulin. And then we have the next organ over here we're going to talk about, which is our spleen. All right, and what does our spleen do? Our spleen does a lot of red blood cell, white blood cell, platelet production. One of the big things that it does contribute to the production of is essentially bilirubin, if you want to break it down into a very simple format, as there's bilirubin. And we also want to talk about right here, which is our stomach. And our stomach does what? It helps with absorption. And particularly the stomach helps with aspirin and alcohol absorption. And then we also want to just over here generalize talking about our intestines. We'll put that here. So our large and small colon. And this also helps with particularly water absorption. All right. And with all of these different organs that help contribute to the blood flow to the liver, we have to get this big vessel here that's helping with that blood flow to the liver. And what is that called? What is this vessel right here called? This big one that leads into the liver, it's really important, is our portal vein. Right. So we have this anatomy and physiology here. We have this layout of our liver, all of these different organs that help contribute to the blood flow that essentially lands into the portal vein and goes up into the liver. And then our liver does its processes of filtering and absorbing and taking things out and putting things in and modifying things in order for them to go to the rest of the body. We need to think about what happens when we have this fibrotic scarring, these nodules that start to occur within the liver. Because our liver has little functioning parts that when all these scars start to occur from chronic long-time abuse or other type of viral illnesses, we have an impediment in that blood flow and that process of the liver. The liver is not able to function properly. And when we look at our patients and we look at the anatomy and physiology, it's, for me, easier to start thinking about what is happening here, so then I can understand the manifestation of all of the blood work and all of the signs and symptoms of our patient. So let's just think for a second, if we have our blood flow, right, and our blood flow is going from our intestine and our stomach and our spleen, all those processes that are occurring, and it's going up in through the portal vein into the liver. And if that blood flow is being impeded, if it's having some issue of flowing, it's going to create some congestion, right? So maybe some issues. And think of it as like a stampede. If you've ever gone to like a big concert and you're all trying to get that cage, the front row right against the stage, you're all running in there. Well, at some point, people start to flow out to the side, and then there's eventually a backflow as people fill in. Essentially, that is happening with the liver here. As that blood is trying to go through the liver, but now the liver is not being able to function as properly as it needs to, creates kind of like a backflow. And when we have that backflow, we have some issues. And I don't want you to think like it's completely going back to all the organs, but it's creating this congestion, this impediment of flow. So things aren't going to be able to flow as properly as they want to. And when that happens, we get some manifestations of our signs and symptoms. And we'll talk about that in a little bit. But why does this occur in our patient? What's going on with our patient that we start to think, uh-oh, they are at risk for cirrhosis? One of the big ones is, the easiest one that people usually know, is alcohol abuse, right? And this is chronic alcohol abuse. This isn't one of those, you have a wild night with your friends, you feel like crap the next day, and you're like, I'm never drinking again. That was absolutely horrible. Your liver will be able to work its way through that and hopefully have little to no damage, and then we will be able to live our life normally. But if we are doing chronic alcohol abuse over and over again, over long periods of time, years and years, eventually we create this fibrotic scarring nodules that are within our liver, and it's not properly functioning anymore, and we cannot reverse that. Another risk factor is going to be hepatitis, specifically B, C, and D. We can also think about other types of damages. What other things can go in and damage our liver? So you can think of things like certain medications and street drugs. So I just say drugs. Any type of abuse like that can also cause issues or impediment within our liver's function. And another one that's really common is a fatty liver. Over time, those liver cells accumulate within the liver, the fatty cells accumulate within the liver, and it impedes the function of our liver. And then we start having chronic problems with our liver and with other organs. So let's think back real quick. If we're having this congestion and we start having issues with our pancreas, you want to start thinking, okay, I'm going to have problems maybe with regulation of insulin. If I'm having impediment of blood flow out of the spleen, I'm going to have trouble with bilirubin, right? Because the spleen helps with our RBCs and our white blood cells and our platelets. And if our red blood cells, the heme is specifically being broken down, a byproduct of that is bilirubin. And then we're going to have an increased amount of bilirubin within our blood. You also want to think about our absorption, especially with things like aspirin or alcohol, and our water absorption. And all of this will manifest within our patients in those signs and symptoms that we're going to be able to identify. So let's go talk about those signs and symptoms now. All right, Ninja Nerds, so now we're going to talk about the signs and symptoms of cirrhosis. And unfortunately, this patient right here has got basically every clinical manifestation or sign and symptom that you could possibly get from the cirrhosis of the liver. So with cirrhosis, we want to start thinking back to that portal vein and back to the impediment of all the blood flow through the liver and what that could look like for all those other organs, and essentially what that would look like in our patient. So the biggest one that is what the NCLEX likes to hit on all the time is the hepatic encephalopathy. And what does that mean? So with hepatic encephalopathy, we're going to have issues with our ammonia within our brain. And our ammonia levels are going to be really high. And that has to do with our liver not being able to detoxify the blood. So what does that look like in our patient? Our patient can have things like an altered mental status. Okay, they're going to be confused. They might have some delirium. They might be seeing things. They're also going to have something called asterixis, which is these tremors within the hands. So if they can hold their hand out straight and not have any tremors within the hand and twitching right in within the arm here, then they wouldn't have asterixis. But it's this tremoring, twitching within the arm. And it has to do with all the neural pathways that we have within our body. With that ammonia level and that altered mental status, they're also going to have things like increase in their bilirubin, because we talked about the spleen is the production site of our red blood cells, and when heme is broken down from our red blood cells, it creates a byproduct of bilirubin. Bilirubin then is not being able to be broken down, so when we have that increased amount, we are going to things like jaundice or icterus, which is the yellowing of the whites of the eyes or the yellowing of the skin, as in jaundice. Because of that, we might also have other issues with bleeding, right? So we want to think we're breaking down these red blood cells, the spleen's not able to produce them, the spleen's not going to be able to reproduce then white blood cells as well. The patient's going to have some issues with platelets, which we call thrombocytopenia. So with that thrombocytopenia, the patient's going to have issues with bleeding, right? So you want to look at this patient and you're going to see things like spidery angiomas on the face. These veins and vessels on the face that are looking like spiders, all right? They're going to have issues maybe with nosebleeds. So you want to start thinking about those bleeding precautions we want to put our patients on. The soft bristled toothbrush, the electric razor. Patients are also going to have something within the esophagus. What is a bleeding risk that we think about all the time with patients that could be manifesting within the esophagus? You want to think of esophageal varices. So we'll abbreviate esophagivarices. All right, and why would that occur? Think about that blood flow. If there's an hindrance of blood flow with the liver and the blood going through the liver, it actually creates a shunt sometimes to be able to shunt out blood around the liver, because the liver is now this backflowing. It's like a rock. It's just impeding all this movement. Because of that, it creates a lot of pressure within the esophagus and allows those vessels to be a little more engorged, a little more enlarged. So when that does happen, now we have these very, very vulnerable vessels within the esophagus that if they are to be punctured, they could bleed, and they can be bleeding out really quickly. So with esophageal varices, we want to start thinking about a patient with cirrhosis and esophageal varices. They're going to bleed really quickly because, again, we have that destruction of the thrombocytopenia and the red blood cells and the white blood cell production being low. So therefore, we're going to have issues with clotting. What else is going to be going on with this patient? They're going to have things like pulmonary erythema, where the hands, usually in women, are red. They're looking red. And they're going to have, what's the one big thing you're probably like, geez, can you just get to that one already? Is the edema, right? And what's going on with the edema? Particularly the ascites and the peripheral dependent. Edema, the lower leg edema. And what's going on with that? Again, we want to start thinking there's a lot of pressure within that portal vein. It's pushing this fluid out and third spacing it. When it third spaces it, we're going to get that ascites within the belly, and they're going to look like they're super pregnant, even though it's going to be a lot of fluid third space in there. And they're also going to have issues with their feet being really swollen. So there's a way we can assess that is by the wave test. If you've never done it or you've never seen it before, if you have a patient in clinical or in your hospital that does have ascites and you have a chance to go assess them, check that out. It's the fluid wave test where you have your patient put their hand right in the middle above their umbilicus, and then if you're able to tap on one side of the abdomen, it should create a wave on the other side of the abdomen. And that's how you know it's ascites. So with this patient, they're going to have all of these manifestations, but the biggest things that we're going to be focusing on is that altered mental status, right? So we want to think about safety, the bleeding, so we want to think about all their bleeding risks, and then the fluid overloaded. And when we start looking at this patient and we start thinking about all the messed up processes they have because of our liver being impeded, we want to start thinking about what kind of labs are going to be abnormal. And with these patients, the biggest test question is usually the liver enzymes. And what are the two liver enzyme tests that we have? We have the AST and the ALT, and we also have the ALP. Now, are these enzymes going to be high or low? I think in your head, they are going to be high. Now with bilirubin, we're going to get a bilirubin number back. Is that going to be high or low? And you're going to be saying high. Why? Because you're expecting them to be jaundiced. You're expecting them to have icterus with their whites of their eyes becoming yellow. Now what about their protein? Is that going to be high or low? It's actually low, along with albumin, which is a type of protein. And why is that? It's because our body isn't able to do the processes it needs to in order to have albumin within the blood, so therefore it's going to be dropping down. What about our PTINR? We talked about this a little bit. Patient is having issues with thrombin. So our PT and INR is going to be prolonged, or it's going to be increased, meaning they're at more of a risk to bleed. Then we're going to have ammonia. We talked about this one too. They are going to be increased. Ammonia is increased because we are not able to do the process of detoxifying the blood, getting that out of the blood, and therefore as it builds up over time within the body, we could start seeing those manifestations of neurological changes, changes in our mentality, changes in our awareness, changes in our hand movements. And what we're looking at there is a patient that's having a possible increase in ammonia. And the last is going to be our white blood cells, our hemoglobin, hematocrit, and our platelets. Those are all going to be low. That again has to do with the spleen. So when we look at this patient, we want to start thinking about what are we going to do to take care of them. If they're having all these issues, we want to start thinking, what are the tests that we can do to make sure that this cirrhosis, is it an alcoholic induced, is it a viral induced, is it medication induced, and then how can we help our patient out with that? So let's go in to talk about these tests here. When we get this blood work done, we're also going to be doing a lot of these tests. But we, as a nurse, aren't doing them, it's the whole team. So the doc's going to order maybe an abdominal x-ray, CAT scan, or ultrasound, depending on what's available, depending on what they're thinking might be the problem. And the biggest things for this is we're just going to be able to identify what the spleen looks like. Is the spleen enlarged? Are we having splenomegaly? What does the liver look like? Do we have hepatomegaly? And what else is going on? We're going to be looking at that ascites within the abdomen, seeing where that fluid is. Is it fluid? How much fluid? From there, we want to also visualize maybe with an MRI the liver as well. We want to hopefully be able to identify if there's any type of lesions or masses on the liver. Maybe there's something else going on that the patient is having issues with, an appearance of cirrhosis, but really there is something underlying going on. And then we'll have one of our gold standard tests of the liver biopsy to be able to tell if we have a benign mass, if there is a mass, or if it's malignant, so that we can figure out what our process is here. And then we also might have the EGD to be able to visualize if there's any varices within the esophagus and any other issues that might be going on. Because what we are looking at here, and ulcers as well. Because what we are looking at here is trying to make sure we are just not saying, oh, our patient has cirrhosis of the liver because of drinking. We want to make sure that we are weeding out with our patient and identifying what is the main cause. Once we do this, we're going to work in through our procedures depending on what these tests show. If the patient needs a paracentesis, which is a draining of that abdomen, we're going to be able to do that. We want to make sure that we do a paracentesis. We are caring for our patient. It's a fluid removal, right? So one of the big things is weights. We want to make sure we are weighing our patient. We're measuring the fluids. So you want to think I and O, right? Because we're going to be taking this fluid, the ascites, basically the fluid in the abdomen, out. They're going to be testing it because this can spontaneously get infected. So we want to keep an eye on that as well. Patient might also have to go if the EGD shows varices. They're going to be getting the endoscopic variceal ligation, hopefully putting in some pressure on those varices so that they don't have the potential to rupture. They might also get a portal hypertension shunting if the patient does have that hypertension, that backflow through the portal vein that's causing a lot of hypertension. They can be able to put a shunt in that'll help bypass that so that the patient doesn't have all the backflow to all those other organs that we talked about. And then if it does really come down to it, if the liver is so unsavable that we would have to do a liver transplant, they would go in to get that transplant as well. And these are individual procedures that we will talk about here on this channel in different videos, but we're not going too in depth with them today. So now let's go in and talk about what are the nursing interventions generally for a patient of suffering with cirrhosis, and what is the education that you're going to be giving that patient when they do go home. So now when we have a patient that we have identified has cirrhosis, there's some common interventions that we can do as nurses, and one of the biggest things is to be giving medication. There's certain medications that we can give, and we're going to run through them really quickly, but we want to start thinking of these patients again as like a fluid overloaded, an impediment of the circulation or process with fluids. You want to start thinking about their nutrition is going to be possibly really bad, and then we're also going to think about their neuro and safety. So when we look at these patients, we're going to be giving medications. What is a medication that we typically use to help with edema? You should be saying we're going to be given things like diuretics, right? You want to be careful with these because patients have already an impaired liver function, they could potentially have an impaired kidney function as well. But we want to look at how we're going to get that edema off depending on the amount of edema that they have. If they didn't get a paracentesis, are we going to be able to get that fluid off of them? If they have portal hypertension or any other issues, we might be using some beta blockers, right? And then you want to be looking at ammonia. So we talked about an increased ammonia level within the patient. Medication that we can give to decrease that is lactulose. And if you've never given this before, never seen it given before, this is a medication that helps the patient go to the bathroom. So they're going to be taking the ammonia that's in their blood. Because it's so much of it, it's actually going to come out in our fecal material. So you want to start having a bedside commode or possibly some chucks, because sometimes patients can actually get diarrhea or really, really soft stool, which is a good thing because we want to get that ammonia level down and keep it down, but it can be a little messy. So if you've ever seen it given, or when you do for the first time, you're going to say, wow, this really does work. The patient does poop a lot. So we also want to think about some supplements them or anything else that is lacking for these patients. So we usually give them some albumin or folic acid, folate, if you will. And you want to start thinking about those supplements that are going to help them as well. And there's a lot of other interventions. It's really case by case, but these are generally the same things or very similar to the things that we're going to be giving our patient. And then they're also going to be on those strict I's and O's. Remember, they're going to have those daily weights. Right? They're going to have issues with their fluid, so they're going to be on fluid restriction. And they're also going to have those neurostatuses. And you want to start thinking about those changes within the neurostatus from shift to shift. Is there a change? Right? How does it work? We want to be asking them what the date is today. We want to start asking them what their name is, where they are, okay? And what is their date of birth. All those things are just those simple little assessments that we can do to say, this patient was fine 2 hours ago, but something's up, something's a little different here. And we want to talk to our patient along with all these different strict I's and O's and those neurostatuses, and how we can talk to the family as well and say, these are the things you want to look for in case maybe medication needs to be changed. But one of the other big things we want to talk about with these patients is sometimes the hard conversation of, what do we need to do in order to prevent this from occurring any further or getting any worse? So usually there's some type of therapy they're going to need. If it was alcohol, or if they're going to need any type of rehab, okay, or any type of other extensive care. Maybe they're going to have to go on some type of other regimen and be seen every couple of weeks. And we also want to talk to them about their diet, their day-to-day diet. There's a lot of things that are going on with people that have cirrhosis. One of the biggest things is they usually have a decrease in appetite. So one of those things is for their diet, we want them to have a high calorie diet, okay? But we want them to have a low protein diet. And you're gonna say, what? And remember, protein is something that then becomes a byproduct of protein is ammonia. So we don't want them having a lot of protein, because then they could create a lot of ammonia within their body. And then the last thing, if you're thinking about all of that fluid overload, you want to start thinking about a low sodium diet. Now, they don't have to eliminate protein and sodium, but we do want them to have a limited amount of it in order to help with that byproduct of what happens when we take a lot of sodium in or we take a lot of protein into the body. So I hope that made sense, Ninja Nerds. I hope you got something out of it. If you did, make sure to give it a thumbs up or comment down below. And then, as always, until next time.